Good evening. Hi, my name is Julian Perez. I'm the Vice President of Risk Management and Compliance at dentalcorp, and I'm very excited to be here with all of you this evening and to be interviewing our esteemed guests. Dr. Kevin Katz is with us. He's an infectious disease specialist. He's the Medical Director of Infection Prevention and Control at North York General Hospital, the head of microbiology at Sunnybrook Hospital, and he's an associate professor in the Department of Laboratory Medicine and Pathobiology at the University of Toronto. Dr. Katz has special research interests in healthcare-acquired infections and patient safety. As well, Dr. Katz is the Chief Medical Officer of PracticeHealthCheck, an innovative company that provides on-site infection control assessments to ensure clinics are adhering to best practices and college guidelines. You can visit practicehealthcheck.ca for more information. I also know from working with him that Dr. Katz has extensive experience working specifically in dental clinics, providing insight into infection prevention and control practices. Dr. Katz, welcome. Thank you for being with us.
Thank you for having me.
So my first question is, after reading that impressive bio, what exactly do you do at those three institutions that I mentioned there, or four?
Right, so at North York General Hospital for the past 15 years, I've been the Medical Director of Infection Prevention and Control. So I do clinical consults as an infectious diseases physician, and I'm also responsible for the systems and policies and procedures to keep patients safe, to prevent transmission of infections between patients and staff and things like that. On the Sunnybrook side, I'm the head of the microbiology lab. And so they're clinical diagnostic specimens. It's one of the largest labs in the city. At the moment, it's COVID-19 all the time. We've been implementing the test and ramping up testing to help out with the provincial response. And then for Practice Health Check, obviously there's been a big focus on infection control in both medical clinics and dental clinics. So that's a company we started to reach out to those practitioners to go on site to provide tailored consultations, help with policies and procedures, infection control manuals, training of staff, and really to make sure that things are in place so that there aren't issues if the college comes knocking. We really are on the clinic side. We're not there to get anybody in trouble. We're just there to get people ready so that patients are safe and everything's in place.
Make sure everybody's trained.
Everyone's trained,
Sure
and all of the checks and balances are there. The steri center's in place, all of the signage, all of the policies, yeah.
Brilliant. Thank you. That's really helpful. So out of those three, is it safe to say that you are busiest at the lab at Sunnybrook now, or are you spread out pretty evenly?
Well, I would say North York General's very large hospital has one of the busiest emergency departments in the province. We've diagnosed probably more COVID cases than any other single hospital, I think, just based on volumes. So I won't minimize that. That's been pretty busy. But the microbiology lab has been equally busy, although I have microbiologists that report to me there, so I have a bit more help on that front.
Yeah. So I'm glad you mentioned that because we've been hearing about a strain on the system, a strain on hospitals, on clinics. It's getting harder for people to get through to public health. It's getting more difficult for people to get tested. I'm hearing a lot of advice throughout Canada asking people to stay away from clinics unless they really need to be there if they have severe symptoms. Can you talk a little bit about where we are in Canada in terms of COVID-19, what it means for our public health administration, and what it means to be in the middle of a pandemic, a global pandemic?
Yeah, I think that's a great question. I think if we go back to the beginning of January when this became sort of sprung onto the front pages of the newspaper, when there was an outbreak that started in Wuhan or Hubei province related to a live seafood market, live animal market. Initially, they were trying to contain it in that city. It clearly exploded throughout all of Wuhan, which is quite a large city of 12 to 15 million people. Quickly spread out from there to multiple cities around China. There was very, very significant efforts to try to contain the spread, to make the virus disappear completely and eradicate it. But then through end of January through February, it was exported to hundreds of countries around the world, and each country started to see patients that presented really we would call them travel related, so that they were imported, they clearly were acquired in Hubei province or another Chinese city. Eventually, we started seeing cases from Iran, from Italy, from a whole bunch of other imported locations. And then as time went on, jurisdiction after jurisdiction started having local transmission, so that initially in Iran, they may have been able to connect the case back to China, but very shortly thereafter, the cases were popping up in people who had never traveled outside of that jurisdiction. So I would say for about a month here, all of the cases were travel related. Recently, over the past 10 days, maybe week, we've started seeing cases that are disconnected from travel, which means that they're acquiring them in Canada. That's happened clearly in Vancouver, and it's also happened in Toronto. I wouldn't be surprised if in the very near future that starts to happen in other places across the country. And so
what does community transmission mean? What does that mean? Because we've been hearing a lot about this. Up till recently, we've been hearing we don't have cases of community transmission. Have we reached a turning point?
I believe we have. Public health, the messaging has been a bit slow. I think if you were to take colleagues of mine and me aside and ask, it's very clear that there is community transmission. We've seen the cases, we've interviewed the patients that are clearly locally acquired. I think the messaging from public health, just today in the media, you could see that the messaging is starting to acknowledge that. So I think to talk about epidemics or outbreaks compared to pandemics, I think that's a pretty fundamental piece to the whole conversation this evening. Outbreaks or epidemics, the goal with those are to stop transmission so that it disappears. And if you look back in 2003 with SARS, that's exactly what the goal was. There was thousands of cases, but ultimately they'd find the case, identify their contacts, and then ring around them, isolate them, and then ring around their contacts, and then within months, essentially, it was eradicated, and there hasn't been SARS transmitting in the world ever since.
Was SARS a pandemic?
SARS was not a pandemic. It was an outbreak or an epidemic. The difference with a pandemic is that we've reached the point where the goal, we're teeter-tottering, I would say, right now. Once you declare a pandemic, you've passed the teeter-tottering, but public health messaging is a little slow. But we've reached the point where essentially it's being acknowledged that the goal will not be to eradicate this from the planet Earth. The goal will not be to contain it and prevent exposure of everyone. It's to acknowledge that, yes, this will continue to transmit. People will be exposed. And the focus eventually shifts to a mitigation strategy where you're trying to essentially reduce the harm that happens from large numbers of people being exposed and developing symptoms. And so
I've been hearing the term flattening the curve.
Right.
Can you explain what that means?
Right. So the mitigation piece is to try to match the capacity of the system with the large numbers of patients that are going to require care. And so a typical outbreak curve will be a typical, bell curve where, you have shoulders and it reaches a peak and it comes back down. The problem with a pandemic, Theresa Tam, the Public Health Agency of Canada's, they call her the top doctor, but the Chief Medical Officer of Health for Canada, essentially said by the end of the year, 50 to 75% of Canadians may be infected with the virus.
So we're talking 15 to 20 million people to more.
They won't be lab confirmed, but that's right. They'll have mild illness, and if you were to do sort of studies on antibodies at the end of the year to see who was exposed, that's right. So a large number of people, the vast majority, 80%, will have very mild illness. It'll be a cold or a fever, and it'll go away, and that'll be the end of it.
So if we're all going to get it, why are we taking all of these measures to try to prevent people from getting it?
Right. So that's getting back to the bell curve, that you have large numbers. Most of them are mild, but 15% will require hospitalization, 5% will require critical care, and 2% will die. So when you're dealing with such a large scope of patients, if that all happens in one big sweep, you'll end up, if we have this many ventilators in Canada, pick a number, and the curve goes up like this, all of these people above it who need ventilators and can't get them will die potentially. So if you can actually blunt the curve or spread the curve so that instead of going like this, it gets pulled out over time and stays below the resources that the healthcare system has in terms of ventilators, in terms of beds, in terms of capacity in the emergency department, then overall more people will do well. And so the way that you do that is with measures that we're starting to see in the media, and public health is starting to communicate. I think they've been a little bit slow in educating the population on why we're doing these things. But essentially getting the kids out of school, asking restaurants and bars to close down or to spread people out and close every second table, to ask businesses to work from home, to on and on and on. In China, they closed the subway systems and closed the buses and all these things. It's to spread people apart from each other so that there's less ability to transmit. It's not to eliminate that, because we will be exposed over time.
Right.
But it's really just to spread out those infections over time so that we blunt that curve.
So social distancing then, that term we've been hearing over and over again, is really tied to flattening the curve. These are
That's right.
Related concepts.
That's right. They're called mitigation strategies. So there's containment, where you try to prevent transmission, which was what happened for a long time up until probably yesterday, today. Public health's going to pivot, and when the pandemic was declared, and you shift to capacity issues, trying to make sure that the system can deal with large numbers of people, and mitigation, where you actually try to minimize the harm and improve the outcomes of Canadians. Not to prevent infections, just to improve the outcomes and survivals.
So then the concept of a chickenpox party, where you get all of your kids together and they all get invirulated.
Yep.
They all get the virus at the same time, and then they are, for the rest of their lives, immune to that virus. Is that the exact opposite of what people are recommending we do right now?
Right, it is the opposite. I could see how people would hear the message and say, well, if I'm going to get it, I want to get it earlier so that I just know and I don't have to worry about it. But essentially, if everybody gets it at the same time, that's part of the challenge. And realistically, I won't put us in the same age category, but at our age, if we were to get infected, our outcomes will be good. There won't be a challenge. We can talk about survivals at different decades of life. But there are, overall, even if the survival at my age would be, say, or mortality rate of 0.4%, which means 4 in 1,000 would die, so 996 will survive.
Right.
If you're one of those 4, that's 100% for you. So to just go play games
your family.
Right. So just go and say, I want to have a chickenpox party. If you're that one person, like that ophthalmologist in Hubei province who tried to sound the alarm bell and then died. Right. If you're that guy, that chickenpox party would be a bad thing. Yeah.
Well, let's talk then. I mean, since you mentioned it, survival rates for different age groups. This has been a question that people have had. Let's start with the youngest.
Yeah.
Should we be worried about our babies, our toddlers, our young children?
Yeah, so I think for the really, really young, I don't think we know the answer. Okay. Like for 1, 2, 3 months of age, I don't think we know the answer, although we haven't seen data showing that it's a problem in those age groups even. Okay. But it is a little bit of a question mark. Certainly we've had one in the city and they did very well, I can tell you that. If you look at kids under the age of 18, very little disease, like very little symptoms altogether, and pretty much zero mortality rates. Mm-hmm. If you go decade by decade, I won't go each one, but from 50 and down, like at around the age 50, the mortality rate's around 0.4%. And then if you jump up to over 80, the mortality rate is above 15%. Okay. So it's really the elderly and those who have immunocompromising conditions that are the ones who are bearing the brunt of the problems.
And what about expecting mothers?
Yeah, so there isn't a ton of data on pregnant women. There was one paper published in The Lancet with 9 women, and they all had lab-confirmed COVID-19, and they all did well. And the babies, they checked the amniotic fluid and the saliva and aspirates from the nose after the babies were born, and actually there was no positive viral samples in the baby. So it doesn't seem to be transmitted in utero vertically to the babies, and the babies all did well. So that's all I know. I think that's all that's been published, but it's not, in H1N1 in 2009, pregnant women were disproportionately negatively affected, as were indigenous populations and others. This one, so far, the data doesn't seem to indicate that.
So I find this interesting. You would think that a virus is a virus. It's either extremely intense and debilitating or it's not. But are there viruses that affect different portions of the population, different age groups, different genders differently? Have we seen evidence for that?
Yeah. Well, I think there's a lot mixed into that question. So it's a coronavirus. You may or may not know that there are human coronaviruses. So there's 4 strains of human coronaviruses. They cause the common cold. They circulate all the time.
So I have heard that. Is this going to be another common cold?
Eventually, it will be after the pandemic. It will become part of the normal coronavirus mix. So there's the 4 human coronaviruses, and then there are other coronaviruses that affect other species. So if you think, there's something called species specificity. So viruses have receptor antigen sort of key and lock connections. So you have receptors in your lungs, and the virus has an antigen that is the key to that lock. And just like I don't get my dog's cold virus, or the dog doesn't get it from me, that's because the receptors and the antigens are species specific.
Okay.
There are non-human coronaviruses, and this one, as an example, is a bat coronavirus in origin. So it circulates in bats. It doesn't cause problems in bats, just like our common cold one doesn't cause problems in us.
Sniffles.
And when it jumps species, that's when you get some trouble. And so that happened with SARS, and that happened with MERS. And essentially, it's, viruses genetically are sort of there to make you a little bit ill and move to the next person. That's like their genetic goal in life, I think. So when you have something that's designed for another species and jumps into a human, it's not really designed for that, and you can get very unpredictable outcomes. So you can get very severe outcomes like MERS with a 30% outcome, or SARS, which was a 12% fatality rate. This one is much lower. It's probably 1% to 2%. But they call them zoonotic diseases, where you have a disease that's for another species that jumps into humans. And there's lots of examples of zoonoses.
So swine flu, for example,
Another
H1N1, that was, I think, the most recent pandemic that we can all reference, which seemed very different. I know even back then people said we're overreacting, but we didn't see anything like the sort of governmental shutdowns that we've seen here.
Right.
Can you talk a little bit about what's the difference between, is it the difference between influenza and coronavirus, or was there something else different about these two pandemics?
Yeah, well, I would say the 2009 pandemic was an unbelievably mild pandemic. I actually think calling it a pandemic essentially set us back in pandemic planning, because it was so mild that people said, oh, if that's a pandemic, we're good. We don't have to do a lot of planning.
I'm guilty of that, certainly.
Yeah. I mean, we all had pandemic plans before, and then it's like, well, if that's what it's going to be, no biggie. So yeah, I think that just wasn't a typical pandemic. It was just a very mild one, because even during H1N1, it tended to be young people and pregnant women and certain groups. But the elderly were not impacted, probably because the elderly had some immunity. So the way pandemics evolve is that it's a new virus. There's zero immunity in the population, and so it's very, very communicable, because none of us we've never had a vaccine, we've never been exposed to it, and it just blows through the population. H1N1, there was some immunity circulating, and so it was a very, very mild pandemic, if you want to call it that.
Right. So in terms of the severity of this pandemic then, I've been hearing wildly divergent mortality rates, depending on what country you're in, depending on what day you're listening to the news. I've heard 4%, and I think recently I heard 0.3%. Can you just explain, I'm not asking you to pinpoint the number.
Yeah.
Can you just explain why we're hearing such wildly divergent numbers, like, by multiples of 10 or more?
Right. I think there's a number of possibilities. It could be the way we are counting, or it could be, in fact, that there is a true difference. And so if you look in China, in Hubei province, the mortality rate was probably they're reporting it to be in the 2% range. I think most people think it was truly closer to 1%, because the way that their system worked was that they would capture those that were admitted to hospital. So they were missing all of the mild cases, and there may have been another twofold mild cases that weren't counted in their denominator. So if you include them in the denominator, then the case fatality calculation drops. If you double the denominator, then it goes from 2% to 1%. If you triple the denominator, then it falls even lower.
Of course.
And so that's the data from China. If you look at what's happening in Italy, the case fatality rate is actually quite shocking. It's closer to 6%. Is it because they're missing a whole bunch of mild cases? Is it because they're only looking at lab-confirmed cases, their lab system's overwhelmed, and they're only testing the severe end of the spectrum and not testing anyone else? So the counting piece may be part of it, but there could be some truth to it in the sense that Italy has the oldest population in the entire world, and this affects old people. So maybe that's a factor. And then Italy has very few ventilators per capita.
Okay.
And survival for this disease does relate to the number of ventilators, respirators you have per capita. So they're very low. Canada has more than Italy, and the US has 3 times more than we have.
Okay, but they're also 10 times the size of us, so I feel like we're doing pretty well.
Adjusted per population.
Oh, okay.
Yes,
That's
per capita.
That's an important
per
piece.
capita, yeah.
How do we get some of their ventilators up here?
Yeah, I think you have a bunch of competing healthcare systems that each have overcapacity in intensive care units, which is not the situation here.
Okay. Before we turn to the next topic, I'd just like to know, are we at a point now where we are turning away sick people from our hospitals, or do you feel that we have the resources so far to meet the rate of admissions to the hospital?
So the hospitals, I would say the average hospital in Canada has 0 COVID patients admitted to the hospital. There might be a few hospitals in Toronto that have 2 or 3 at this point. At the peak, we can anticipate there would be hundreds. And there may be, we normally have 14 or 15 ventilated patients. We're trying to plan potentially to have 45, 50, or 60 ventilated patients. So that's pandemic planning to generate the capacity to deal with it. So right now, there's not a huge capacity challenge in terms of the numbers admitted to hospital. There's definitely a lot of anxiety, a lot of people coming in who are very anxious. And
high blood pressure,
no question.
admissions.
And then there's a lot of people who are looking for testing, so there's a lot of people coming through Emerge asking for testing, so the volumes are high on that front, but they're walking well who have, common colds or fevers. And then even the ones who are tested positive, almost all of those are really well. They just have colds, maybe a little fever, and they're sitting at home. So, but this is sort of the beginning of the shoulder of the wave.
Okay.
And then very quickly, it doesn't just grow linearly, it grows logarithmically. So it actually, doubles. That thing where you ask your kid if they want a penny and double it, or do they want to get $100? You always take the penny that doubles and doubles and doubles and doubles. Sort of that situation. Yeah.
And if your kid takes the exponential growth one, you just tell them you don't have the money.
Yeah, that's right. Exactly. That's right. Yeah.
They never trust you again. So, can you tell me a little bit? Well, first, a question I've been getting a lot is, how long are we going to be in the middle of this crisis? When are we going to be back to normal? I'm hearing from you, most hospitals have 0 cases, and we have states of emergency declared.
Yep.
We have plays, sports, events, gatherings, parties, universities, schools canceled. We have dental offices being asked to shut down or to only be providing emergency care. The Ontario Medical Association asked all of its members to only provide medically necessary treatments and not elective treatments. This is a massive disruption to people's day-to-day life. People are laid off. They're going to not have a paycheck. People are stuck in foreign countries or fear being stuck in foreign countries shortly. This is really I've never lived through anything like this.
Yeah, I don't think any of us have.
When will we see these measures relax? And are they going to get worse before they get relaxed?
So I'll preface it by just saying these are my predictions.
Come on, you've got insider knowledge.
Yeah, I can tell you these are my best guesses. Don't hold me to it. We can have another interview if you want, maybe in 4 or 5 months and see how it went.
I'll grade you.
Yeah, exactly. I think, in general, epidemic waves and pandemic waves tend to crescendo up and decrescendo down over an 8 to 12 week period. So you sort of take, say, 6 weeks to get up and 6 weeks to come down the other side. That's true with influenza every season. So you may say, oh, great, we're good for May. But recognize that pandemic waves, you can have 2 or 3 of them before before the vaccine's available. So do I think this journey will be over and done with super quickly? I don't. Do I think that the measures that public health will implement will become more intense, not less intense? I do. And when will we start to see that things are changing very significantly in the healthcare system? I would predict that within the next, say, 2, 3, 4 weeks, we'll see a very different place than we are right now.
In which way?
That we will have large numbers of patients admitted to hospital, large numbers of patients on ventilators potentially.
And if we don't see that, it'll be a success.
That would be great.
But a lot of the politicians, I imagine, will be blamed for overreacting.
Yeah, well, that's the challenge for politicians, and I'm not one to necessarily defend politicians. But you see, if they do overreact and put these measures in place and there isn't a big surge, then they get criticized for societal disruption, economic, turning down the economy and things like that.
The next pandemic.
And if they don't do enough and it's a disaster like it is in Italy and Spain and Iran and South Korea, then why didn't they do more? So I think in this one they're a little bit damned if they do, damned if they don't.
Right.
But you just have to look at numerous countries, many countries across Europe, South Korea, Iran, China itself. Very significant problems in all of those places. So I don't think that this is a false alarm.
Okay.
Yeah.
So then you would recommend heeding public health's advice, it sounds like.
Yeah, I would hope that public health messaging would be a little bit better in terms of trying to have the population understand why they're suggesting what they are. Because if the kids are out of school and it's like, oh, party, and everybody's at Yorkdale at the mall, or big house parties with 20 kids, it
well, I can
defeats
tell you
the
on
purpose.
my block, all of the kids from school are getting together and having street school.
That defeats the purpose. The whole reason for getting schools out is so the kids aren't mixing with each other and transmitting viruses. And the reasons for closing bars and restaurants and all of these, it's all to keep people apart so that the virus doesn't spread. So if everyone's high-fiving that everything's out, that defeats the purpose. And I think that public health could do a better job to explain why these measures are put in place.
So in terms of public health's response to this, sometimes I get a little bit confused about what the national public health agencies, what their powers are, what their role is, versus the provincial public health agencies, and then we have our local public health units. Do you think that segmented, fragmented approach to public health is a strength of the Canadian government, or would you rather see strong leadership that, for example, in China, maybe not that strong, but can say, 40 million people or whatever our population is, we're going to give one unified single directive to everyone? Or do you think it's better that we have this region-to-region approach?
Yeah, well, I don't think that China's strength was because of their public health system. Definitely totalitarianism and dictatorship makes control of a situation like this easier. There's no question about that. Liberal democracies, the populations will tolerate less than China would, and then even within democracy, if you start looking at Singapore as an example, the population is much more used to the government giving them direction and everybody follows it. Whereas here, not exactly like that. Everybody has an opinion. So in terms of the way it works, there's the Public Health Agency of Canada, which essentially sets the overall direction. The Chief Medical Officer of Health, David Williams in Ontario, for example, has powers to write directives, which essentially all the local public health units and healthcare institutions need to follow. And then local officers of health, local medical officers of health, can write orders, essentially, that are supported by legislation that says this has to close, schools have to close, you're not allowed doing that, and they can enforce it under penalty of mobilizing the police if they wanted to.
So they can enforce it, but 99% of what I've seen so far is we strongly recommend you self-isolate. That seems like, first of all, let's talk about what is the difference between self-isolation and quarantine?
Yeah, so one is voluntary and one is mandated. So at this point, essentially for true quarantine, there's really just travelers from 3 locations, from Hubei province in China, from Iran, and from Italy. Those are the only ones where they say if you come from there, because there's such a big problem, that you are mandated to stay self-isolated in your home or quarantined. Whereas for everyone else, it's a recommendation, please do it for your own good and for others. So it's not on penalty of anything, it's a request.
And so if, let's say you were told tomorrow by public health, you contracted, I'm not going to
Yeah, it's fine.
Sorry.
It's okay.
You'll probably get it from your
I'm not
children.
paranoid.
You'll probably
That's
get it
right.
from your kids and
That's
not
right.
at work.
Yes.
But let's say you get it at work and you test positive and they say, we want you to self-isolate for 14 days. Are you going to go to the supermarket on your way home to buy what you need? Or are you going straight home and you're going to now have to rely on your network to try to help sustain
So
you?
firstly, let me tease apart the time period. So if you're exposed, now I'm going to give it to you. So let's say you have it.
Now I have it.
And I'm exposed to you, then I would need to be self-quarantined for the 14-day incubation period.
Right.
Because the incubation period has a median of 5 days, a range of 2 to 11 days, and then they add the extra little bit just for safety.
Okay.
So that's from exposure until I will develop disease. That's the incubation period. That's
Symptoms.
when I self-quarantine.
When you say disease, is symptoms?
Symptom onset.
Okay.
Yeah. So the piece that you talked about was when I actually am a case, so I have symptoms, how long do I need to self-isolate before the transmissibility is over? And that's a little different.
Okay.
And the data is a little bit mixed, but what most people are saying is a minimum of 7 days and 2 days after your symptoms are resolved. So if your symptoms resolve on day 7, it would be 9 days. If their symptoms resolve on day 3, it would be 7 days. So a minimum of 7 days plus 2 days.
So then, I think this is an important question that a lot of people are wondering. If I haven't developed symptoms, can I spread it back to you? Well, you may be immune at this point, but to the cameraman. Can I give it to the cameraman?
If you're asymptomatic and you have
asymptomatic.
it. Yeah, so I think that's the big million-dollar question everybody wants to know the answer to. The short answer is that there may be asymptomatic transmission. If there is, and it's not clear that there is, it probably represents a very small proportion of transmissions, and it certainly isn't what's driving the outbreak. There was one reported case in New England Journal of Medicine, which is the biggest medical journal that there is, and there was a woman who was from China who flew to Germany. There was an industrial training conference, and she left, and then a day or two after she left, she was on a plane, and a few of the workers in Germany came down with symptoms. There's a couple of things there. You don't tend to have very intimate contact with your colleagues in a training session, so it's quite communicable. And the workers in Germany said that she was asymptomatic, so that the authors published it as asymptomatic transmission.
Okay.
They were quite embarrassed a couple of weeks later when actually people tracked the woman down in China and actually interviewed the woman, because it's one thing to ask the workers, and I think you look well, but you may not feel well. They interviewed the woman, and she actually did have chills and aches and a prodrome, a viral prodrome, the night before the training session, and she took Tylenol. So she wasn't truly asymptomatic. No. She had mild symptoms, and so she was communicable. It's very hard in China when you have 80 or 90,000 cases of transmission to know whether it was asymptomatic transmission. You may think you got it from me, but you've been walking around and there's another 75,000 people who have it, so you may have been exposed to somebody else, and it really wasn't your exposure to me that gave it to you. So
you're saying that we
don't know, essentially,
hundreds of thousands of cases of coronavirus, and we still don't know if asymptomatic transmission is a thing.
Yeah, well, influenza, there's been probably 100,000 research publications on influenza, and even with influenza, we're still not 100% sure whether asymptomatic transmission is a thing, because it commonly circulates. It's actually very hard to control all the variables in a natural sort of human population to know with 100% certainty. But I think we can take comfort in the fact that it's not common and it's not driving the outbreak. It may happen rarely.
Okay. So I don't know if you have heard, you've been very busy over the last few days, I imagine. I don't know how much sleep you're getting, and even when you're sleeping, I don't know how restful the sleep is.
Yes.
But in dentistry, one of the big stories over the last few days has been that at the Pacific Dental Conference, which is one of our biggest conferences in the country, there was, I believe, one dentist who came home from Germany who attended the conference and was very active there, went to a number of the booths, and then on the last day started to feel under the weather and decided to cancel some of the events, and then shortly thereafter was tested positive. Mm-hmm. And at first, the health authority said, don't worry about it, everybody, it's fine. The risk of transmission is extremely low. Mm-hmm. And earlier today or late last night, they flipped the script a little bit and they said, everybody who was at the conference, is 15,000 people, self-isolate.
Right.
So this is something that everybody in the western part of Canada, the dental world, is thinking about because, well, for the 15,000, it's straightforward. It's extremely difficult to self-isolate. Mm-hmm. Associates are having to cancel their patients. Hygienists are, in some cases, laid off taking sick leave. In some cases, they are on vacation, not your ideal vacation right now. While we understand that, based on an increasing number of confirmed cases at that conference, what about the colleague, the person who was working with the dentist that came back from the PDC? Should the entire office self-isolate, or should we be limiting it, as public health has suggested, just to the dentist who's come back?
Yeah, so I work with public health. I am not in public health. Okay. I don't aspire to be in public health. There's things I like and things I don't like. Okay. That's not something, that I want to do. They do have a tough job. There's no question, and they do need to make decisions. I think that if you had 15 medical officers of health that looked at the situation, some of them would say, oh, the whole conference, and others may say, okay, let's identify the person and see who did they actually shake hands with, who did they interact with, because they have the authority to break privacy rules and identify people so that they can find those at risk. And others may say, well, let's start with their office, their spouse, their family, and if they have problems there, then we'll go wider than that. So there's different ways to skin it. And I can't say why they didn't at first and then they freaked out afterwards. It could be that there was new information and they knew that all of a sudden there was a second case and it was, oopsie, we need to actually broaden that net.
Well, that's helpful in terms of the decision-making process, but I think, so let me reframe my question. So I was there, I'm at the PDC.
Yeah.
So I come back, we're partners, we practice, we're both dentists.
That's a different question, got it.
So then I get the phone call from a friend, did you see the news?
Right.
What? You have to self-isolate for 14 days. And I say, oh, damn.
Okay, that's a different question.
But I tell you weren't there.
Right. So that's a very common question in the hospital. I get all different versions of anxiety and paranoia, and I was in contact with this person, and they were in contact with that person, and all combinations of who was symptomatic and who wasn't symptomatic, and who traveled and who didn't travel.
Right.
The short version of the answer is, if you were in the conference, so you were exposed, if you're asymptomatic and I'm exposed to you, there's no issue for me. So I'm only at risk if you actually have the disease, and you're only at risk if you were exposed to the person who had the disease. So it doesn't jump through the person.
Right.
So that's the short answer of your question.
Right. So I guess the same thing would apply then to people who are returning from abroad and being told to self-isolate. Mm-hmm. So let's say my wife just came back from vacation in Europe.
Yep.
She was told, you need to self-isolate for 14 days. We're living together. Right. Our home routine is whatever it is.
Right.
I can still go to work as long as she doesn't become symptomatic.
That's right.
Okay, so that's...
And then the chain of incubation periods would also apply. So she's counting 14 days because the incubation average is 5 days, range of 2 to 11 days. So if she were to come down ill on day 8, God forbid, then your incubation period would start day 1 of 14 from her day 8, and hopefully you would separate yourself. You'd go to the basement, she'd go upstairs, and then you'd count 14 days from the time you broke exposure to her. So the times are person by person based on the exposure. So her exposure ended
Okay.
when she left Europe.
Okay.
Count 14 days. And if she becomes symptomatic on day 8, you count 14 days from when you got exposed to the virus, and the virus was only there when she got symptomatic.
Okay. Let's talk a little bit more about this idea of exposure. So another scenario that comes up is a patient who may be COVID positive.
Mm-hmm.
So if they come into the clinic, try to arrange an appointment, and walk out of the clinic, and then they call a few days later and say, by the way, I was COVID-19 positive. Knowing what you know about dentistry and the way infection spreads,
Yep.
what are you doing at that dental clinic?
So I think the first thing is to really do a careful interview of the person
Okay.
to figure out when they were symptomatic, because that's very, very important. So
Right.
if that person had a dental visit on the Monday,
Yeah.
and then they had symptoms develop on Thursday,
Right. Don't worry
no
about
issue.
it. Okay.
Yeah, no issue. If the person came on Monday and then they on Tuesday went and got a test and they were positive, and then you interview them and say, well, I've actually had the same symptoms going back to Friday, that's more of a concern for
Okay.
sure. And really, so the break point I think that people are using in general is guidance, and it's not necessarily perfect, but generally speaking, if there's a 2-day gap from the time of symptom onset, then you'd say that's not a concern.
Okay.
So it's pretty common when people fly over here, so they land on a Monday, they get sick on a Wednesday. The question is, do we need to bother with the plane, which is a big deal for public health.
Right.
And
of course.
so
they've gone all over at that point.
Well, and they're sitting in a plane,
Right,
and there's
right.
recirculated air and
Yeah.
everything. So generally, public health is using 2 days for that, and
Okay.
there hasn't been. We've had lots of planes
Okay.
like this, and there hasn't been a problem.
So screening for symptoms works.
Screening for symptoms works.
That's
It
what you're
does.
telling me.
Yeah, I think that, clinics should really focus on the pre-screening, both for symptoms. Now that the travel is falling apart a little bit, but for the past couple of months, travel was a really important thing to ask for too.
Right.
The symptoms you ask for are fever, chills, and new onset respiratory symptoms, runny nose, sore throat, cough,
Right.
myalgias, aches, pains, things like that. And that viral achiness you get, all of those mild things, if they have them, then essentially defer the visit. So you can have
Can you
your
run through the symptoms one more time? I just
Sure.
want to make sure, because I know everybody wants to know, what's the telltale sign, if you will? And
well,
then
there's
what
the,
are
there's
some other
the telltale
symptoms?
sign, and then there's the so I would say some of the early reports were like 95, 98% had fever and cough.
Okay.
Very, very common. Less than 5% had runny nose.
Right.
It was pretty uncommon to have runny nose. Sore throat was sort of in the middle. I think it was 20 or 30%.
Okay.
So fever and dry cough were the big one, not producing any sputum.
Right.
But definitely since then, people have seen very mild cases where they have just upper respiratory, sort of nose stuffiness, sore throat,
Common cold type
common
stuff.
cold type stuff, and then they don't all have fever, especially as they get older, and then the aches and myalgias, aches and not feeling great, tired type of
Okay.
thing. So if people aren't feeling well and it's an elective visit, cancel it. That's what we're doing
Okay.
at the hospitals. If it's an emergency situation, we can talk about that. It's a little different.
Right. We'll get into that.
So screening is very important. We used to have travel. I think that the feds and the provinces need to move on past travel. I think their focus on travel is actually doing a disservice to the population, because the Canadians don't really understand that this is transmitting now locally in Vancouver and Toronto and soon to be
Okay.
everywhere. And by obsessing around travel and telling people who have just come back from Europe or the
Yeah.
Caribbean
Yeah.
to go and self-isolate, in my mind, maybe we should have done that 6 weeks ago, but now, there's
Too
more.
late.
There's more cases in Toronto than there are in Jamaica and Mexico. So
So that's what I had a question earlier today. My mother came back from India, and she's living with me. And I looked up, I Googled India. I don't know what
Right.
their testing is there or their public health system, but it was fewer cases than in
Right.
Canada with a far, far, far larger population. I
Right.
said, it's funny that we're having this conversation, because it
Yeah.
seems like if your mother was in Canada this whole time, we'd have a bigger risk.
right. If we go to Jamaica, Jamaica's going to be asking, "Oh, you're coming from Canada."
Yeah, exactly.
Right. So I think that the whole connection with travel, a week or two from now, no one will be talking about it anymore.
Which is a relief, I think, to a lot of people who are abroad or leave vacations. But I guess it's also an unknown, right? You don't want to leave the country and not be able to come back in.
Right.
So that's certainly a risk of disruption to your life. So let's go back to screening a little bit. You call, you ask, you're saying basically, do you feel unwell at this point? That's the question you're asking.
Yeah, fever, cough, and then you can ask specific symptoms, but ask, do you feel unwell? And then if they say, I feel well, then you can just validate it with a couple of other, no fever, no cough, no shortness of breath, no.
Okay.
And if they say no, then you can ask about travel, because travel, at this point, travel is, from some of these countries, is very risky. If they were just in Italy, or they were just in Iran or one of these places that have a lot of it, then they may be more at risk than an average Torontonian. If they came back from Jamaica or Mexico, they're probably about the same as us. Yeah. So there still is a little hint in that, but as Toronto, Vancouver, and the rest of Canada has more and more and more.
We're not going to be worrying about that for long.
Right.
So as community transmission becomes more of what's happening, we're going to see probably greater social distancing type mandates and fewer travel restrictions. What about internally? Do you think at any point, tell me honestly, is Toronto going to be locked down? Is Vancouver going to be locked down? Yes.
Yeah, I don't think so. If you look in New York State, there is one little community that had a lot of spread that they seem to be trying to lock it down. It seems a bit arbitrary.
Okay.
But yeah, I don't think that'll happen.
Okay. So that's a relief. So another question we've come across is what happens if a patient wants their filling done, right? Their insurance is going to expire tomorrow. They want that filling
that's
done,
a crisis.
Right? They want that. Okay. Well, first of all, we'll get into
just joking.
Emergency care, what to do with that. But there are still provinces where it's business as usual.
Yep.
PEI, for example, I think they've had one case. They're doing great out there.
Right.
So in any event, you call someone, they say, I'm feeling fine. They're not feeling fine. They come in, and they cough.
They say they're feeling fine.
They say they're feeling fine. You screen them. Come on in. I'll see you tomorrow. They come in. They cough. You look at them a little skeptically. They sit in the waiting room for a minute. They cough a few more times. The dentist decides to take their temperature. They have a fever. Are you turning that person around and sending them home at this point?
Yeah. I mean, if you think they look unwell and they have a fever, for sure you're turning them around. Yes.
Okay. So you're not just relying on subjective symptoms. You're observing the patients as they come in.
Yeah, I don't think people are deliberately going to lie. I haven't experienced
Their
that
insurance
a lot.
Is expiring.
Oh, I forgot about the insurance. Yeah, I forgot about the insurance.
It's
I'm sorry.
a thing. Trust me. Trust me.
Yeah, in the hospital system, people don't deliberately lie unless there's a real reason, but it's quite unusual. But yeah, if you have objective evidence that they have a fever, or you can tell that they're stuffy, or that they look unwell, I would just turn them around.
Okay, so once the patient is screened, this patient is okay to receive treatment. They're in the office. It's a business day. We're treating patients. What are some of I know your bread and butter has been to advise dental clinics and a number of dental clinics that dentalcorp works with, associates with, and operates. You've done a fantastic job in our clinics, by the way.
Thank you.
But what are some of the measures now that you're adding to your typical infection prevention and control regime to try to be extra cautious with patients in the era of COVID-19 pandemic?
Yeah, I mean, I think just in general, and this is new, so I don't know that they've rolled out broadly, but I think the types of things to think about are the screening issue. I think about your waiting rooms, because with social distancing, we want to keep people separate. So you can take away every second chair. You can, when people come to check in, if they're there early, you can ask them to wait in their car, and you can text them when you're ready for them. You can schedule your appointments so that people aren't showing up at the same time. Ask people not to show up early, to show up on time, things like that. So the scheduling is very important. I think making sure with the pre-screening that they're well, and don't forget about the staff. The staff are also super important because staff are motivated to come in. They don't, if they're part-time workers, they may not have benefits. They may not get paid if they don't come. In hospitals, the staff are, in my mind, as risky as patients and visitors because I always say that the staff person the physician goes and sees 15 people down the hallway, whereas a visitor just comes and sees their loved one and leaves. So if you have an unwell visitor,
Right.
it's a much lower risk than having an unwell physician or nurse who's working.
Right.
So making sure that your staff understand that you want them to be healthy and not coming in to work when they're sick. And that's just good in general. If people have
Absolutely.
vomiting, diarrhea, and are coming in, everyone's going to get
Right.
norovirus in a winter
Right.
season. And then there's some specific things in terms of taking temperature. The ADA recommends you take temperature.
Okay.
It may be a little bit unwieldy to do it.
If patients take an Advil or Tylenol before they get there as well, it might not be the most helpful, but it's worthwhile.
I mean, you can ask them, but yeah, they are recommending it. I think most people know if they're feeling febrile, if they're feeling cold or chilled. They are recommending take it. And then in terms of personal protective equipment, to have the right equipment on when you're doing procedures. There's a mask, but don't forget the eye protection.
Right.
I don't see it as often in dentistry as in medicine, where people think, oh, I don't need the eye protection piece, or my prescription lenses are good enough.
Right. So if a droplet gets in your eye, that is one way this
100%.
virus can spread.
Yes, 100%. And then there's other things like rinsing the mouth with an antiseptic before procedures.
Give some
may
examples.
reduce it. Like hydrogen peroxide or
Chlorhexidine.
Not chlorhexidine. Chlorhexidine is more for bacterial.
Okay.
Povidone iodine
Okay.
you can use. Things like that. And then
What about Listerine? I've heard that. Is that
they
something
say
that's
it. I don't think the
effective?
percentage of alcohol is quite high enough to do it.
Scotch, then.
Yeah, that's right. Like 120
40%.
proof, something like that.
No, but in seriousness, so hydrogen peroxide
Yeah, so
solution.
pre-rinses to try to reduce viral loads. Although, again, if people are asymptomatic, it shouldn't be a concern.
Okay.
And then other things like rubber dams, high capacity evacuators or suctions.
Okay.
All those things will reduce aerosolization and droplets.
Okay. So let's talk about, you just used an interesting word that before today I don't think I'd ever said was aerosolization. So aerosols is all the rage right now in dentistry. I believe it was on Saturday, the Canadian Dental Hygiene Association. You've seen that? Put out a notice to all of its members. So someone in every dental office got this notice, and it said that aerosols are caused in almost every dental procedure, and the aerosols have the capacity to spread throughout the entire clinic and the potential to infect everyone in the clinic. It said something to that extent. If there's an asymptomatic patient, is there anything to worry about with regards to the
if they're asymptomatic,
aerosol?
then there shouldn't be virus there. So you're not going to aerosolize the virus because there's no virus.
Right.
Right. So if there's no COVID-19 there to aerosolize, there's not really an issue at all.
Okay.
The concern would be more if you actually have a positive patient, so they're symptomatic, and then you actually use the high-speed handpieces or ultrasonics or
Trophy jet.
Yes, exactly. That those can actually create droplets, and there are two big types of droplets that we talk about. This sounds very scientific. The large droplets and there's small ones. So
what about the medium ones?
The large ones. So we talk about in terms of precautions or additional precautions. There's droplet spread diseases and then there's airborne spread diseases. And so droplet spread diseases are larger droplets, and they're large enough that gravity actually pulls them down to the ground. So if I'm coughing and sputtering and sneezing, that generates droplets, and those droplets fall usually within 2 meters. For an adult, for a kid, they can't cough as strongly, so maybe a little bit less. And 2 meters is about 6 feet. And so if you're in that 6-foot zone, then you would need to use personal protective equipment to prevent those droplets from falling on your mucous membranes, mask, eye protection, and then gown or gloves.
6 feet. So I've been hearing this 2-meter rule.
Right.
So this is part of where that comes from.
Yeah, it's a droplet spread disease. And then there are smaller droplets, or aerosols, some people call them. It's a little bit of a more vague term. Where they're so small that they can get onto air currents, and they're so light that they can just waft around.
Even in a enclosed indoor environment.
So measles, chickenpox, TB would be examples of that. And so measles is unbelievably contagious because it's airborne. So if you can be in a large room like this, and if I'm measles positive and you guys are non-immune, so you haven't been vaccinated, you've never been exposed.
And you sneeze.
And we have 100 people here. You don't even need to sneeze, just breathing the air.
Wow.
18 people will come down with measles on average in the room. So because it's airborne and it just floats through the air and just sharing the same airspace leads to transmission. So I think...
So where are we? What is COVID-19? Tell us.
So COVID it's clearly a droplet spread disease. It's not an airborne spread disease. And there's been a lot of discussion around the masks because for airborne spread diseases, that's when you use the N95 respirators that are well sealed to the face and fit tested and sealed checked. And then for the droplets, you can have a loose-fitting mask that just covers the mucous membranes along with eye protection.
To avoid the direct hits, basically.
Exactly. So this is clearly a droplet spread disease like influenza, like RSV.
How do we know that? I'm just saying this because the New York Times, over the weekend, you probably saw that article, had a list of the most exposed or the most at-risk professions, and dentistry was almost off the charts. And I think it was partially this idea of these aerosols in the air. So how can we tell that it's just a droplet? Not just a droplet, but it's a droplet spread
you can tell
virus.
based on the transmission dynamics that it happens. So if it was an airborne disease in a plane, if I had it, then I'm in row 20, somebody in row 2 would come down with it. If it's a droplet or contact just from touching, then the people in the immediate chairs around them may be at risk. And so it's been like that, where it's just the immediate contact, the family member who's been at risk. There hasn't been just somebody walking through a space where somebody else gets it. There's also been just empiric data because Ontario had been recommending N95s up until recently. They just dropped that recommendation to go in favor of droplet.
Or is it because they ran out?
No, the CDC was running out. That's why they changed it. But BC and essentially all the provinces except for Quebec and Ontario have been recommending true droplet with a surgical mask from the beginning. So all of those cases in BC have been cared for with a surgical mask, and there's not been any healthcare workers acquiring it. So I think for a whole bunch of reasons, it's clearly a droplet spread disease.
Great.
That doesn't mean in dentistry, though.
I'm worried.
Yeah, some of these. So if you had a true case, would I say that it's not advisable to use high-speed handpieces and or these Profi ultrasonics, things like that? You should probably avoid those things in a true case because it will generate droplets. And I don't think that they'll waft out into the hallway, but they will get more onto your shirt and onto your face.
If I can wear the mask and the hood, but it still might get on my cheek. And then later on, I could do that.
So, I think if there was emergency procedures in somebody with a lab-confirmed COVID case, then it would make sense to take more precautions if you did have to use those things. And probably those cases would end up being in a situation where you have the appropriate engineering controls with the air and the N95s and things like that.
So let me ask you a question then. You're a receptionist now. And you're taking calls at the front desk. You're welcoming visitors. You're updating the day sheets. And 3 operatories down the hall, a patient is having a emergency surgical extraction done, and you have to section the tooth using the high speed. There's aerosolization happening. Are you worried that that mist is going to carry through the air and land on you, or do you think it's really just the clinical team around that operatory who have to worry at this point?
Yeah, so I mean, I think there's a few things mixed in there. So if you were to ask me that question last year, no COVID around, the same question would be a reasonable question to ask, and no one is concerned in that situation, So I think in this situation, would I say that it would be advisable to take somebody who's a lab-confirmed COVID case at the severe end of the spectrum and take them into the room and do that and start sectioning through? Nobody would tell you to do that. I think if you have procedures in place where you screen the patients, where you, for example, check the temperature, that they're feeling well, there shouldn't be a concern of sectioning the tooth. If the patient is well, there shouldn't be a concern. And then I'll just bring in the piece way back from the beginning that this isn't about containment, that we're all going to be exposed.
Right.
So, here we're talking about the concern about being exposed at work, and we just need to remember that the way that most of us are going to get exposed is by taking care of our kids, by going to pick up groceries. It's going to be everywhere. So
because you let down your guard more in your daily life too. I bet you at the hospital might be a little bit more cautious about the hand rub than you're with your friends. Or
and when you're at the clinic, you've screened the patients, you make sure they're asymptomatic, you make sure they don't have fevers, you make sure they're well, gloves, PPE, and then you go to the grocery store. So how do you actually know the person that's checking you out and handling all your food didn't take an Advil or is feeling well? Or nothing. There's no screening. So it's actually a more risky situation. And then kids really are incubators of viruses. So the kids shed viruses. They're slobbering over each other.
They go to groups. They come back.
Exactly. So I think those are much less controlled circumstances than the situation that you're talking about in the clinic, where you can actually ask the questions, the circumstances, you can use personal protective equipment to control the situation.
Okay. So that's really helpful. So let's talk about this then. At the clinic, right? Let's say it's a busy day. You've got people in the waiting room. You've got staff coming and going. You have the hygiene team has a meeting and they have lunch together. You have the doctors who share an office and they're talking. They're using the same keyboard.
Right.
And then they put on all their PPE. They clean their hands. They put on their gloves. They treat their patients. They doff their PPE is the term of art. Turn over the operatory. Where in that office are you worried about contracting COVID-19 at this point? Mostly.
Yeah. So firstly, a lot of those things that you described shouldn't be happening exactly that way. So they should be spatial separating. They shouldn't be having lunch very close together.
Right.
There shouldn't be a whole bunch of patients in the waiting room. Out of all of that circumstance, if you're doing the screening properly and people, aren't all the stuff with shaking hands and interacting physically with each other.
Okay.
Let's say you're doing all of that properly. The parts that I would be most nervous about, I don't know about the dental clinic.
Yeah.
If I went to the grocery store or to the mall,
Yeah.
The door handles, the elevator buttons, all of the high-touch surfaces.
Right.
So, disinfecting those high-touch areas where large numbers of people are coming through. And again, your dental clinics are going to be screened, so it should be a lower risk. But just to talk about the disinfectants a little bit. So these coronaviruses, they're enveloped RNA viruses. They're actually pretty weak viruses. Any disinfectant will kill them. And so you could use, in a dental clinic, you have to use a healthcare approved product.
DIN number.
With a drug identification number. So you can use cavi wipes, or you can use hydrogen peroxide-based stuff or bleach-based stuff, whatever. Any of them will kill it. Make sure they're nice and wet, because it's all about the wet contact time. So if it's dry, it won't be wet long enough. They generally need to be wet for about a minute. So if it's nice and wet, it'll stay wet for a minute. At home, Lysol, Clorox, any of these things will work. On the hands, alcohol hand rub, I should say, works really well. Actually, better than soap and water, as long as that's 60 or 70% alcohol. It's a rub, so you don't just put it on and then do this. You actually need to rub and get
it
all
evaporates.
The surfaces. Yeah, but if you do this, it doesn't work. The rubbing actually disrupts the cell membrane more. Yeah.
Okay, so it sounds like the standard infection prevention control measures of cleaning surfaces, of wiping high-touch areas, washing your hands, antibacterial hand rub, of cleaning waiting room, minimizing crowds, screening patients. It sounds like all of this works.
Right, and then there's a couple of additional pieces with the rubber dams and the evacuators, just because if you're using high-speed handpieces, it will generate more aerosols. You can see it when the light's on.
Yeah,
so if you have a rubber dam, dental dam, and the evacuator, it'll pull those aerosols in.
Good HVAC system with the right amount of pressure and that kind of stuff, and you should be able to fairly safely treat. So let's talk about N95s for a second with the training. Just because I know a lot of people out there haven't had the opportunity to get
fit tested.
Yeah. Can you talk just a little bit about what do you do when you put on an N95? I imagine that you're fairly adept now at donning and doffing the N95.
Yeah. So, personally, most people get fit tested onto one model. So It essentially relates to the shape of your face. There's different models of masks. Some of them are, the round ones. Some of them are the duckbills. Some of them are pleats. And they fit people's faces differently. Some people have skinny faces, small faces, larger faces. Essentially, to be able to be fit tested, you have to be clean shaven. That's a requirement. And then you pick a mask. Often in hospitals, we pick the models that we have most of because it's easier.
Yeah.
And then essentially they put a hood on to the person with the mask on, the little hole. And they have this little squeeze bottle that they put a compound called Bitrex into it. And then they squeeze, which creates these aerosols. And you breathe. And they ask if you taste the bitterness, and if you say no, then they say, okay, well, count 1 to 10, and they keep squeezing it and making aerosols. And then if you still don't taste it, then you're turning side to side and counting the alphabet, or saying the alphabet and up and down. So essentially, with all different movements of your face to make sure that seal still works. And if it takes about 5 to 10 minutes, and then they'll give you a little card telling you what your mask model is. I'm fit tested on multiple different models just so that whatever's around, I know it fits me, just because I use them quite a bit. And then every single time you use it, you're supposed to do what's called a seal check. So you put it on, and then you essentially cover it and make sure that it's pulling through the filter as opposed to around the edges of the filter.
So that's the goal, is you want it coming in and out.
So there's a good seal around the outer margin, whereas a surgical mask is loose on the outsides and essentially it catches those large droplets that are going to fall, but it doesn't prevent air from going in the sides.
So that's excellent. So I can ask you a question now. This is
the first one, right?
This is the first question. This is the only question. So let's say you are working in a community where there is a very low rate of COVID-19. Your public health authority so far has said it's safe to practice. The Dental Regulatory Authority says it's safe to practice. Maybe there is one case in a town nearby, but basically you're close to zero, like a lot of Canada still is. It's your dental practice. Are you opening up and treating patients with the additional precautions that we've discussed?
Yeah, I mean, I think if it's not circulating widely, obviously dentists provide a very important service to the population, and yes, you would continue serving them. I think in Toronto now and in Vancouver, it's a little bit different. There's starting to be community transmission, which is why I think they're starting to implement some of these measures. But if you were in an isolated community and there wasn't any, I think it would be reasonable.
Thank you. That's helpful. And that was the question I was dying to ask all that. So to work up the courage to it. So I'm going to do a bit of a speed round here. I'm just going to ask you a number of questions. So before the webinar, we asked our participants to send us some questions, and we received a number on what are actually effective measures that can be added to the typical day-to-day procedures. And I think we've covered some of these, but we're going to go over them again because I know that people are interested in hearing the answer from an expert here. So here's one. Patient comes in, asks for a mask and gloves. Do you provide them with a mask and gloves?
Yeah, I think the answer is no. I would also ask them why they're asking. So if they're not well, they should turn around and go out. And the other factor is, which we didn't talk about at all, is in pandemics, there's a huge issue with supply chains, right? Because this is a global issue, and it's happening in multiple countries at the same time. And so, Canada wants a lot of masks and eye visors and things like that, and respirators, and so does every other country in the whole world. And so right in the middle of it, China manufactures the majority of it. Their factories were closed. The swabs for testing are made in Italy. We're not getting them.
So Italy's hoarding them all.
The factories are closed. So the supply chain is a huge issue. So you can't buy masks very easily. So I think they are a precious commodity that we want to use for our staff. And so knowing why they want it, they probably have symptoms they should leave, and then also preserving it for your staff because that's what it's for. In what kinds of treatments is a class 1 mask reasonable PPE for a clinician? Yeah, so the class 1, 2, 3, the ASTM classification, those are just level of fluid resistance.
Okay.
So as you go up, they're more fluid resistant. At the lower levels in class 1s, it would be just for exams and checks and things like that. As
No
you go
aerosols.
Up, yeah, as you go up and you're using the scaling and ultrasonics and things like that, then you would go up the class on the level of mask for fluid resistance levels.
So I've been hearing a lot also that masks used in the general public are not effective. One of the things that I've heard said is that if you wear it for too long, it becomes soggy or something to that effect. Is that
well, there's a whole bunch of things mixed in there. I don't know if it's a quick snapper, but so the best evidence for the public using masks is if somebody's symptomatic. So somebody who's symptomatic putting a mask on actually does protect other people.
Protecting other people.
Yeah,
is what
so
it's for.
it catches the droplets and protects other people. Wearing a mask when you're well to protect yourself against other people, I mean, it works in healthcare because we're trained how to use it and we use it for shorter periods of time. If you watch the public, it's down on their neck, it's under their nose, they constantly have their hands up to their face, and probably it's actually increasing the risk because they're constantly adjusting
touching the mask so much,
and contaminating themselves. Yeah.
Right.
The other piece was, so how long is a mask good for, or an N95 respirator? It's a big topic these days because again, you can't buy it with gold. They're not, they're on allocation or on back order. And so essentially you can wear an N95 respirator or a surgical mask until it is wet or damp, or until the respirator has resistance to breathing, which is usually when it's wet or damp. So they're good for a long period of time until they are wet, or the surface of the mask is contaminated. Okay. So in dentistry, for example, if you were to wear the mask and then be using a high-speed handpiece or doing scaling with an ultrasonic or something like that, the surface of the mask would be considered contaminated and it should be changed. Right. If you wanted to preserve that mask for multiple patients or if you were running out, if you put a visor on top of it, then the surface of the mask would be considered clean. Right. And then you could change the visor or clean the visor and use that mask for a prolonged period of time. And in hospitals, we're starting to do that where they're not necessarily being changed between patients. This piece, they'll change the gloves and use hand sanitizer and change the gown so that they're not transmitting virus between patients for patient safety, but for the staff, as long as you don't put the hands up to the face.
Touch it with the hands that are
contaminated. And as long as the mask is covered by a visor, then it's not contaminated.
And the visors can be wiped. That's the kind of surface you can wipe.
Yeah, I mean, it depends which kind of visor. There are disposable visors. Some of them, you can wipe them. Other ones, they're so thin that it's actually very challenging to do it.
But if visors are easier to get than masks, then you've got to decide what your resource allocation is. Okay. So about the toys in the playroom, do you get rid of those?
Get rid of those. Even on a general, like last year, you should get rid of the fuzzy toys. If you're going to have toys for the kids, they should be things that you can put into a hot dishwasher cycle. But now I would just get rid of all of them. Okay. In a time of COVID-19, when everybody's particularly cautious, would you recommend gowns versus the lab coat that you wash every day? Yeah, I probably, if gowns are an option, I probably would recommend gowns and gloves. Again, if you're screening the patients really well, there's not a major need to change things dramatically from day to day. The way this transmits is very similar to influenza. So if we're not crazy paranoid about influenza, people aren't getting their flu vaccine, it actually is very similar in terms of how it transmits. It's a respiratory virus that's transmitted very, very similarly.
Okay, so you're screening the patients, but the patient is the 7-year-old who fell down
kids
and
are a
broke
whole
a couple
different
teeth.
Thing. Yeah.
But the mom's bringing the child. Is that part of your screening? Who's bringing the child? Who will be there? And how are they feeling? How do you do that?
Yeah, I think you would ask the secretary receptionist to screen everyone who's coming in. Yeah.
Ask people to limit the visitors to the bare minimum. No siblings, friends, etc., coming to the appointment.
Yeah, it's interesting. I haven't considered this much in dentistry. It's a big factor in hospitals. There's no question to try to limit the number of visitors coming in.
We're coming up on spring break, and everybody's out of school anyway.
It's a good question.
The mom's got all kids.
Yeah, I mean, I think if you can limit the number of people that are in the room, it makes sense. also from a spatial separation perspective, right? Most of the dental operatories are not humongous. So if you want to keep 2 meters between everybody, you can't have 1 million people in that little space anyways.
Right.
Yeah.
Yeah. How about asking people to stay away from the operatory? I mean, again, it's talking about some of the droplet transmission.
Yeah.
And keep the mom or the concerned spouse in some cases in the waiting room.
Yeah, I think with kids it's a little bit harder, but yeah, spouses shouldn't be there. They can take a
They're
walk.
also going to go sit in the same car together or share some water. But in
no,
any event.
no, it's more the staff being
Yes,
exposed, I
right.
think, is the question than to each other.
Right.
Yeah.
Okay. What questions should I have asked you? If you're putting your hat on as an IPAC consultant for medical and dental offices, what are you doing in the hospital differently? I went to Sunnybrook, for example, for dental. They have a dental clinic there, excellent dental clinic. And I went to shake hands with the doctor who was there, somebody I know, and he said,
we're not doing that anymore.
So tell me about that.
Well, I mean, hands are known to be very, very common vectors. There's some funny videos if you search online where there's one from Northern Europe where people come in and instead of shaking hands, they kiss each other because it's like French kiss each other because they thought it was better hygienic than the hand washing. It's just a joke. But I think, there's been media headlines in Italy where there's no more double kissing on the cheek. And I think socially now, because of the social separation, there's more elbow bumps or just greetings without touching.
Finally is getting,
props.
Yeah, exactly.
Yeah.
So that's a reasonable precaution. Don't shake hands with patients, staff, friends. Just try to limit.
Hands are definitely a common source. If you actually think about how often you touch your face,
too many
it's
times,
very, very common. So if you don't shake hands, it's one less time to need to sanitize your hands with alcohol hand rub. And you definitely should be sanitizing your hands frequently, certainly before you go up to your face, before you eat food, after you touch elevator buttons and door handles. Not to be crazy paranoid, but frequent hand hygiene sanitation is definitely a big thing, and trying not to touch your face. But that's not so easy.
That's not
so easy.
One other question for sure. I don't know if it'll be the last, but it's definitely one other question that I've heard is how long does it live? Like you said, it's very easy to kill, but how long, if I cough, I have COVID-19, it lands on that table.
Yeah.
How long is it on that table until it gets wiped off?
Yeah, so the studies haven't been done in COVID-19, but they have been done with the human coronaviruses, and the answer is a few hours to a few days. So it can stay there for a while. Okay. Bacteria and viruses are different. Bacteria can actually replicate on surfaces. Yeah. Viruses, by definition, this is like the philosophical question of, is a virus alive or not?
Right.
Because viruses can't replicate. They need human cells to actually replicate, whereas bacteria are free-living organisms. So if
we're getting owned by now, we're getting owned right now by something that's not even alive.
Well, that's a question. Yeah, but if it's on the surface, it's not going to multiply and increase. It will just sit there, and then if you touch it, and then touch your face. But yeah, hours to days, very easy to kill if you actually do wipe it with.
So hours to days, we don't know. We're still figuring that out with this particular virus.
Yeah. Well, I mean, it is hours to days. We know that for regular coronaviruses. The reason why there's a range there is it depends on temperature, it depends on humidity, it depends on sunlight. There's all these different things can kill it or help it survive.
We were talking earlier about aerosols and in terms of the rate of dissipation. For an aerosol in the air that's hanging in the air, can it be there for days as well?
So, and COVID-19 isn't that, but let's say measles.
Measles. We're talking about measles
So
now.
if we talk about measles, so it depends on the air circulation in the room. Right. So you can get HVAC engineers that can come and actually tell you how much time it takes to exchange the air in the room completely. So in hospitals, we actually have that tested twice a year. So I can tell you that room has an air exchange of 6 per hour, and that one has 12 per hour. And whether it's negative pressure to the hallway or positive pressure to the hallway. And so based on the number of air exchanges per hour, you can figure out how long it takes to clear 99.9% of the air. There's tables. So essentially, if you have a reasonable air exchange, the air will be circulated within about an hour, max 2.
And again, that's not a COVID-19 concern.
Not a COVID.
It's really gravity that we're worried about the time.
That's right. That's right.
Okay.
Yeah.
Well, we got hundreds of questions from our listeners. I think we've covered a lot of them, surprisingly. It was an absolute pleasure
Thank you.
talking to you. I know that you haven't been sleeping much, that you've been very, very busy, that you're very sought after right now for your expertise at both hospitals, by your clients in dental clinics and medical clinics. And I really appreciate you taking the time to spend with us, to share your thoughts, your opinions, and your knowledge. So thank you.
Pleasure.
And I'm just going to give you an elbow bump.
Thanks,
and,
Julian. Yeah, it was
so
a
the
pleasure.
next time. Thank you, everyone, as well, for joining us. We hope that you found this to be an informative and useful discussion. It was a pleasure presenting to all of you. And on behalf of dentalcorp, I would like to thank our guest, and thank you all for attending. Have a great evening.
Stay healthy. Yeah.